Hello, and welcome to the Universal Influenza Immunization Program, the 2021-2022 session. My name is Jessica Andrews. I'm a public health nurse with Peterborough Public Health in the Infectious Disease Department. I'm sure that this topic is probably old hat for a lot of you listening, and you may notice that it's a little bit different this year. We are going with a pre-recorded session, but I do still encourage any questions or comments can be sent through, and we'll discuss that later on in the presentation. So thank you for being here with me and listening. I will be your presenter today. The agenda for this session will include the following. We'll look at an influenza overview, as well as flu activity last season. Immunization in the era of COVID-19 will also be a topic that we'll be discussing, and we'll be looking at the NACI recommendations for this year, as well as product mixes and information. We will also discuss adverse events following immunization and where to locate resources. For an influenza overview, we know that the causative agent for influenza virus includes three different types, A, B, and C. Types A and B are of public health importance since they both have been responsible for epidemics. Influenza subtypes are classified by the antigenic properties of their surface glycoproteins, hemagglutinin and neuraminidase. Illness occurs when there is exposure to the virus through large respiratory droplets, where hemagglutinin binds to the epithelial cells of the upper respiratory tract through salicylic acid found on the surface of our cells. The virus uses your cell's mechanisms to replicate the virus's genetic material and utilizes neuraminidase to detach from the host cell, where it will undergo apoptosis and the virus will move on. This process takes about 8 hours. Frequent mutation of the genes encoding these surface glycoproteins results in the emergence of new strains. Influenza A H1 and H3 subtypes and influenza B are associated with widespread seasonal epidemics. Signs and symptoms of influenza and COVID-19 both have consistent and similar symptoms, and they include but are not limited to usually a sudden onset of new or worsening cough, shortness of breath, fever, sore throat, runny or stuffy nose, headache, myalgia, and lethargy. Loss of taste and smell has also been reported, but seems to be most consistent with COVID-19 versus influenza. Both diseases can result in pneumonia, and flu and COVID-19 can be either mild, severe, or potentially fatal infections. The incubation period for influenza is usually 1 to 4 days. Whereas with COVID-19, the incubation period is usually between 2 and 14 days, with a median of 5 days. Communicability for influenza. You can become infectious 24 hours prior to symptom onset. Viral shedding of nasal secretions usually peaks during the first 3 days of illness and ceases within 7 days, but it can be prolonged in young children, the elderly, and those that are immunocompromised. Well, there's still a lot that we don't know about COVID-19. We do know that you may become infectious 3 to 5 days prior to your symptom onset and up to 10 days after that. Transmission of both of these viruses are predominantly spread via respiratory droplets, which are released or shed from infected persons when they sneeze, cough, or talk. These droplets can travel up to 2 meters or 6 feet. They may enter the host's eyes, nose, or mouth, or fall onto surfaces in the immediate environment. Some of these viruses may remain viable for extended periods of time, and therefore contact transmission can occur by touching contaminated objects or surfaces and then touching one's face or eyes. There is a difference, however, between COVID-19 and influenza. The reproductive number, or the number of secondary infections caused by an initial infection, for COVID-19 is higher than influenza. And now with the Delta variant, that number is even higher, twice as high as we once thought, estimated to be between 5 and 8. Here is a chart that can show you some similarities and differences between influenza and flu taken from Johns Hopkins Medicine. The source is located at the bottom of the screen if you choose to print this off, if you want to share this with your clients when they're asking about the differences and similarities. And the impact of influenza. Worldwide, influenza is responsible for 1 billion cases. 3 to 5 million of those are severe illnesses, resulting in 290,000 to 650,000 deaths. Nationally, in Canada, influenza and pneumonia are among the top 10 leading causes of death. 30,000 lab cases are confirmed each year. We will be looking at this as last season was quite different. There's usually 12,200 hospitalizations and 3,500 deaths attributed annually to influenza. What is happening globally? So here is a graph taken from the Australia Government Department of Health. Often public health officials, they'll look at this data from different regions to try and predict the severity of the upcoming flu season. This graph was pulled, like I said, from the Australian government, outlining confirmed influenza cases per year over the past 5 years. And the red line is actually the current flu season that they're experiencing. This indicates a couple of things. One, and the obvious one, is that public health measures that are utilized for COVID-19, such as social distancing, universal masking, can actually be effective against other respiratory viruses like influenza. So those things that we have been telling our clients and our patients for years, they actually work. So as of September 7th, 2021, Australia is reporting 483 notifications of lab-confirmed influenza, and there have been no influenza-associated deaths reported. As of this time last year, Australia was reporting 21,119 cases of lab-confirmed influenza and 36 lab-confirmed influenza-related deaths. And if you go back a year further to the 2019 flu year, this number was quite higher at 272,146 confirmed cases and 662 deaths. Now let's look at our local influenza data for the 2019-2020 influenza year and the 2020-21 year. And you can see through this chart there are some striking differences. In the 2020-2021 influenza season, the number of lab-confirmed cases of influenza were very low in Ontario, reported at being less than 30. Since the emergence of COVID-19 in Canada in January of 2020, the detection and containment of COVID-19 transmission has been the focus of health professionals across Canada. In March of 2020, public health measures such as physical distancing, hand washing, and masking were implemented to reduce the spread of COVID-19. And those measures coincided with an abrupt end to the 2019-2020 influenza season in Canada in mid-March of 2020. Seasonal influenza circulation in Canada and worldwide has remained low since the spring of 2020. However, influenza immunization still remains important due to the potential of increased influenza activity during the 21-22 influenza season with the gradual relaxation of these measures. NACI recommendations for influenza vaccine. Vaccination is recommended for everyone 6 months of age or older without contraindications, and that includes those at high risk of influenza-related complications or hospitalizations, and those that are capable of transmitting influenza to these high-risk groups. So who are the people that are at high risk of influenza-related complications? All pregnant women, adults and children with chronic conditions including cardiac or pulmonary disorders, diabetes, and other metabolic disorders, cancer, immunocompromising conditions, renal disease, anemia, neurological or neurodevelopmental symptoms or conditions, morbid obesity with a BMI of 40 or greater, children and adolescents aged 6 months to 18 years who are undergoing treatment for long periods with acetylsalicylic acid because of the potential increase of Ray's syndrome associated with influenza. People of any age who are residents of nursing homes and other chronic care facilities, anyone over the age of 65, all children 6 to 59 months of age, and Indigenous peoples. All of these individuals are at high risk of influenza-related complications or hospitalizations. Also, a focus should be those that are capable of transmitting to high-risk groups. That includes healthcare and other care providers in facilities and community settings alike. Household contacts of high-risk individuals, child care providers, service providers in closed or relatively closed settings, for example, a crew on a cruise ship, essential community services, people in direct contact with culling or with poultry infected with avian influenza. Healthcare providers and care providers can spread this through their activities and are capable of transmitting influenza to those at high risk. In household contacts, these include adults and children of those listed on the previous slide, whether the high-risk individual has been immunized or not, and household contacts of infants under 6 months and members of a household expecting a newborn during influenza season should also be included. The importance of influenza immunization in the era of COVID-19. The influenza vaccine is the best defense against getting and spreading the influenza virus, helping to save lives and reduce the strain on our healthcare system. Every year, individuals with influenza and influenza-related complications increase the burden on the healthcare system in the fall and winter months. During the COVID-19 pandemic and potential COVID-19 circulation this fall, while we do know that we are in the fourth wave, it is essential to prevent morbidity and mortality related to influenza to reduce the burden on the healthcare system and to ensure that there is capacity to respond to the COVID-19 activity. And just yesterday, we received from NACI some exciting information. The co-administration of influenza and COVID-19 vaccine is acceptable. So COVID-19 vaccines now may be given at the same time as or any time before or after other vaccines, whether or not they are live, non-live, adjuvanted, and non-adjuvanted vaccinations. Informed consent should include a discussion about the limited data available, as well as the benefits and potential risks of administering a COVID vaccine and a non-COVID vaccine at the same time. There are no specific safety concerns that have been identified when routine vaccines are given at the same time or within days of each other. However, there is a possibility of an increased temporary side effect when the COVID-19 vaccine and another vaccine are administered at the same time or within days of each other. Allowing COVID-19 vaccines to be given at the same time as or within days of other routine vaccinations will help facilitate the rollout of the 2021 influenza vaccine program this fall and winter, and will make it easier for individuals to receive other routine vaccinations that they missed during the pandemic. Vaccines administered during the same visit should be administered at different injection sites. As with other vaccines, when possible, administration on the same day is preferred to vaccines being given within a few days of each other. Studies looking at the simultaneous administration of COVID-19 vaccines with other vaccines are underway and ongoing, and NACI will continue to monitor this evolving evidence and will provide updates and recommendations as needed. Offering vaccines in the context of COVID-19. There is guidance now available from NACI and the Ministry of Health, which we discussed in previous slides. It's also important to consider space and timing of clinics and screening patients based on your specific needs for your organization. The use of physical barriers as much as possible, and staff wearing medical masks when they are near clients within 2 meters. Gloves are only required for intranasal immunizations, and of course, proper hand hygiene between clients is essential. Clients should also be wearing non-medical masks for those that are 2 years of age and over. And please continue to report adverse events following immunization as well. Influenza activity in Canada is usually low in the spring and summer months and begins to rise over the fall and peaks in the winter months. Depending on the year, the peak may occur as early as fall or as late as spring, so ideally, vaccination occurs before the onset of the influenza season. Although vaccination before the onset of influenza season is strongly preferred, vaccine may still be administered up until the end of the season, although its utility may be compromised if exposure to influenza has already occurred. The antibody response after vaccination depends on several factors, including the age of the recipient, prior and subsequent exposure to antigens, and the presence of immunocompromising conditions. Humoral antibody levels, which correlate with protection by the vaccine, are generally achieved by 2 weeks after immunization. However, there may be some protection before this time. Annual vaccination is required because the body's immune response from vaccination diminishes within a year. Also, because influenza viruses change often, the specific strains in the vaccine are reviewed each year by the WHO and updated as necessary so that there is the greatest possibility of matching the circulating viruses. Dose and schedule. Influenza vaccine is a single dose for children and adults, except children 6 months to under 9 years of age receiving the seasonal influenza vaccine for the first time in their life should be given 2 doses with a minimum interval of 4 weeks between. It's recommended that 2 doses for flu vaccine only occurs in the first season that a child under 9 receives a vaccine. So, for example, if you have a 5-year-old appearing in your office and they've received only 1 dose of flu vaccine last year, this was their first time that they were receiving the vaccine, and they appear in your office again this year. They do not need to receive 2 doses this year, they would just need to receive the 1. So I know the topic that everybody wants to discuss are what products are going to be available this year. So here is the product mix, and there are 6 vaccine products that are going to be publicly funded for the age groups as outlined. There are 4 quadrivalent vaccines which are recommended for various ages based on the product, and new this year there is a high-dose quadrivalent vaccine for the use in individuals 65 years of age and older. And this is a new addition. As you may remember, last year there was a high-dose vaccine. However, it was trivalent, meaning there was only 3 strains in that vaccine. And this year it will be a high-dose quadrivalent. Flucelvax has also is now also available to be utilized for anybody over the age of 2, which has been updated from previous last year when it was only authorized for those 9 years of age or older. And an old familiar, Fluad, is being added back into the mix as an adjuvanted trivalent vaccine for those that are 65 years of age or older. So here is another table just showing the product mixes and the ages that they are appropriate for. And there are some important notes. Fluzone quadrivalent and Fluzone high-dose quadrivalent are different products. Fluzone high-dose quadrivalent is only authorized for those 65 years of age or over, so it is important to use caution when administering Fluzone products just to make sure that they are going to the right person. Fluzone high-dose quadrivalent and Fluad are going to be available through primary care providers, participating pharmacies, retirement homes, long-term care homes, and hospitals. As you can see, FluMist is not publicly funded for this influenza season. And just a reminder too, that trained pharmacists can now administer publicly funded influenza vaccine to individuals 2 years of age and older. And here you can see what the World Health Organization vaccine recommendations for the Northern Hemisphere are. And you can see that there are slight differences between the egg-based vaccines and the cell or recombinant vaccines. So Flucelvax quadrivalent vaccine. It is a mammalian cell-based culture vaccine, And it's got similar immunogenicity, safety profile, and effectiveness to egg-based inactivated vaccines. It's newly licensed this year, like I said, for those that are 2 years of age or older, where it was previously licensed for use in those over the age of 9. And NACI states that Flucelvax quad may be considered among the inactivated influenza vaccine quadrivalent vaccines offered to adults and children over the age of 2. And it is expected, as I said, to be delivered to public health units. So egg supply is not needed for this vaccine production, which can result in a quicker mass production of this vaccine if required in the event of an influenza pandemic. It uses a cell lineage derived from a Cocker Spaniel kidney from 1958, and it can be used in individuals with dog allergies. And Fluzone high-dose quadrivalent. And so there is a NACI statement that does state that high dose should be used over standard dose given the burden of influenza A disease and the good evidence that high dose provides better protection compared to standard dose in adults 65 years of age and older. Other than a recommendation for using the high dose over standard formulations, NACI has not made comparative individual level recommendations on the use of the other available vaccines in this age group. In the absence of a specific product, though, any of the available age-appropriate influenza vaccines should be used. Fluad. This year, Fluad is made available again through the UIIP. Fluad is an adjuvanted inactivated influenza vaccine that is targeted to persons 65 years of age and older. The adjuvant is designed to improve the immune response to the vaccine, which is important since older individuals may not respond as well to influenza vaccination as younger individuals. The adjuvanted vaccine is a trivalent vaccine, meaning it is designed to protect against 3 influenza viruses, 2 influenza A viruses, and 1 influenza B virus. There are some contraindications and precautions. So influenza vaccine is contraindicated in people who have developed an anaphylactic reaction to a previous dose of influenza vaccine or an anaphylactic reaction to any of the vaccine's components, with the exception of egg, or those people that have experienced Guillain-Barre Syndrome within 6 weeks of influenza vaccination. So egg allergy, it is not a contraindication. NACI has concluded that egg allergic individuals without other contraindications can be vaccinated against influenza with any product without a prior influenza vaccine skin test and with the full dose. The vaccine may be given in any setting where vaccines are routinely administered. Again, some more contraindications and precautions include oculo-respiratory syndrome, or ORS. In Canada, during the 2000 and 2001 influenza season, ORS was reported after administration of the influenza vaccine in some individuals. Symptoms include redness in both eyes that are not itchy, plus 1 or more respiratory symptoms occurring within 24 hours of influenza immunization, with or without swelling of the face. Since the 2000 and 2001 season, there have been far fewer cases of ORS reported per year. Individuals who experienced ORS symptoms in the past may be safely re-immunized with influenza vaccine, except for those who have experienced ORS with severe lower respiratory tract symptoms, including wheeze, chest tightness, and difficulty breathing within 24 hours of their immunization. These individuals should seek medical advice before being immunized again with influenza vaccine. And as discussed, Guillain-Barre Syndrome, the absolute risk of GBS in the period following seasonal influenza vaccinating is about 1 excess case per 1 million vaccinations, and the risk is much lower than the risk of GBS associated with influenza infection. So what are some precautions? This advice may be obtained from local medical officers of health or other experts in infectious disease, allergy, and immunology, or public health. In view of the considerable morbidity and mortality associated with influenza, a diagnosis of influenza vaccine allergy should not be made without confirmation, which may include skin testing by an allergy or immunology expert. If an individual is found to have an allergy to a component in one influenza vaccine, consideration may be given to offering immunization with another influenza vaccine if there is a formulation not containing the implicated component, in consultation, of course, with an allergy expert. Individuals who have an allergy to substances that are not components of the influenza vaccine are not at increased risk of allergy to influenza vaccine. Individuals with symptoms of acute respiratory infection, including minor symptoms such as a sore throat, should be recommended to be tested for COVID-19 and complete the self-assessment tool on the ministry's website. If the individual tests negative and otherwise passes the self-assessment tool, influenza immunization may be provided. Adverse events following immunization, or as we call it, APHEs. This includes any event or reaction that occurs after receiving a vaccine, which does not necessarily have a causal relationship with the administration of the vaccine. And it may be coincidental, but under Health Protection and Promotion Act, it must be reported. For influenza vaccines, the ORS and GBS within 6 weeks of immunization are of particular interest. So if you do experience this or have any clients that are experiencing these kind of reactions, it is really important to complete the form that's located on the Public Health Ontario website and to fax it off to Public Health for Medical Officer of Health recommendations. Vaccine safety and adverse events. There are common adverse events that happen with vaccines that we see quite frequently, including redness, swelling, and soreness at the injection site, headache, tiredness or weakness, and sometimes fever. These are generally mild and they do only last for a few days. We do know with the high-dose vaccine that there are higher rates of systemic reactions as well, so that's something just to keep track of. Serious events are rare following immunization. It's difficult to determine the relationship, whether it be because of the vaccine or due to other illnesses that are developing at the same time or other health conditions that may be showing up at the same time as immunization. Allergic responses are rare, a consequence of a hypersensitivity to some vaccine components. Now we're going to be talking about immunization with healthcare workers. And NACI considers the provision of influenza vaccination to be an essential component of the standard of care for all healthcare workers for the protection of their patients. Indeed, many organizations have made statements calling for mandatory immunization as a condition of employment for healthcare workers. So here is a look at our coverage rates for the last 2 seasons. And you can see with Peterborough, the hospital, as well as long-term care homes, they have increased their percentage of coverage in both sectors, which is good to see, as well as across Ontario as well. And just to let everybody know as well and to have this in the back of their minds, COVID-19 vaccine status in Peterborough. So as of September the 24th, 79.3% of adults, so those that are 18 plus, have received their second dose. And youth, 69.7% of those youth have received their second dose as well. And these stats are always changing as we are immunizing more individuals, but you can visit the website. The link is there in this slide for more information about vaccine stats and where clinics are going to be located and clinic information if you have any clients that are still needing their COVID-19 vaccination. And where can the public get the influenza vaccine? So there are lots of different options. Healthcare provider offices, pharmacies. We do have about 40 pharmacies locally that are going to be offering the vaccination. We will be holding a flu clinic in Millbrook again this year, and that is because they do not have a pharmacy that participates in the UIIP. And we will also be doing kids clinics for those unattached patients under the age of 2, and they will be by appointment at Public Health on selected days in November, December, and January, and those dates will be posted up on our website soon. And here are some resources that are available for influenza. The UIIP website, of course, they do have information there, fact sheets on specific products and for age groups, and they have a healthcare provider Q&As as well on their website, as well as looking at the NACI 2021-2022 statement on seasonal influenza. The World Health Organization has some information as well. And there is the Public Health Ontario Respiratory Bulletin that you can see kind of the current status of cases in Ontario. There are the product monographs, as well as there is information located on our website. So I just wanted to kind of take a pause here for a second. As we are just recording one session this year, we are going to record it for all of the sectors. So this specific part of the presentation is actually going to be focused on respiratory outbreaks directed to long-term care homes and retirement homes in regards to outbreak prevention and preparation. So if this does not pertain to you, please feel free to stop listening here, and I do thank you for your time. If there are any questions related to the influenza program, please direct them to Peterborough Public Health by calling 705-743-1000, extension 131, between the hours of 8:30 to 4:30, Monday to Friday. And please note that even with the best planning and intentions, issues can arise with distribution and procurement. Procurement occurs at the ministry level, and Public Health has an allocation of influenza vaccines for this season. So without further ado, we will go into speaking about respiratory outbreaks now. In this section of the presentation, we'll cover the following topics: prevention, preparation, and surveillance. It will also cover outbreak management, including IPAC measures, outbreaks in the time of COVID-19, transfers from hospital, antivirals, and when to declare an outbreak over. Remember the saying, plan for the best, but prepare for the worst? In healthcare, especially with still being in a global pandemic, we always need to be prepared for the worst. Key factors for appropriate outbreak control include having a good supply, including NP swabs, line lists for cases, hand sanitizers at entrances, appropriate signage, and personal protective equipment. Policies and procedures for immunization and antivirals, outbreak management, contacting family members regarding outbreaks, and for cohorting of staff and or residents if that's needed. Staff education should also focus around awareness around those policies and procedures, how to take an NP swab and complete lab requisitions, what to do if an outbreak is suspected, when to contact public health, and those initial IPAC measures. Documentation, of course, is crucial, which would include, but is not limited to, those who work at other institutions, who is immunized and who isn't, consent for antivirals, onset of symptoms for staff and residents. So preparing for outbreaks. We here use this document, a guide to the control of respiratory infection outbreaks in long-term care homes. and it is on Peterborough Public Health's website. Chapter 2 speaks to the importance of the influenza vaccination and provides lots of good information on prevention and preparation for the influenza season. An important goal of surveillance is to ensure early identification of symptoms in residents and staff that precede a potential outbreak or an outbreak in its early stages, so that IPAC measures can be implemented as soon as possible. With the COVID-19 pandemic, surveillance has been increased in both staff and resident populations. Long-term care homes are required to have ongoing surveillance programs to determine the presence of infections. Key features of these programs include a sufficiently sensitive surveillance program to identify sentinel events and trends, analysis of surveillance data by the infection control practitioner in order to trigger actions designed to reduce or eliminate disease transmission and influence policy and practice, and sharing of surveillance data with administration, the IPAC team, and the public health unit as necessary. There are two types of surveillance, passive and active. Passive surveillance involves the identification of infections by staff whose primary responsibility is resident care, while they are providing routine daily care or activities. Active surveillance involves actively seeking out infections on a regular basis by individuals trained in surveillance, so usually infection control practitioners. Several strategies may be used, including, but not limited to, conducting unit rounds, evaluating unit reports, reviewing charts, and pharmacy records. Whenever there are 2 cases of acute respiratory tract illness, we could be looking at a potential outbreak. Peterborough Public Health should be contacted. If it is determined that an outbreak is occurring, a case definition specific to the outbreak will be developed in collaboration with public health. Case definitions include signs and symptoms, time of onset of illness, and if applicable, the location of resident or staff in the home. Case definitions can be altered, and they can be unit specific if needed. This is specific to an unknown respiratory outbreak. In the next slides, we will discuss outbreaks in the time of COVID-19. Here you can see some of the key differences between an influenza or a respiratory outbreak and a COVID-19 outbreak. Please note that these recommendations can change with more information that we obtain for COVID. Every symptomatic resident should be tested for COVID-19. If you are seeing an increase in the amount of symptomatic residents, public health should be notified, as there may be a respiratory illness other than COVID circulating in the building. Consultation with public health will help to determine if an outbreak needs to be declared, and which type of outbreak, whether it be a respiratory unknown outbreak, influenza, or COVID outbreak, needs to be declared. A COVID outbreak is defined as a suspect outbreak in a long-term care home is defined as one single lab-confirmed COVID-19 case in a resident. A confirmed outbreak in a long-term care home is defined as 2 or more lab-confirmed COVID-19 cases in residents or staff in a home with an epilink within a 14-day period where at least one case would have reasonably acquired their infection in the home. Only public health can declare an outbreak and declare when it's over. In the event a resident living in a long-term care home develops symptoms of COVID-19, asymptomatic residents, regardless of their immunization status, living in the same room should be tested immediately along with a symptomatic resident under the direction of public health. And of course, this would be something that would be discussed with the home with public health consultation. Now to switch back to influenza outbreaks, we do have an additional tool that we don't have available for COVID outbreaks, which is the use of antivirals. Tamiflu is covered for institutionalized individuals, which includes retirement homes, during a public health confirmed outbreak of influenza A or B. This can be discussed with public health if you are unable to to obtain antivirals during an outbreak. So what about antivirals for staff? Antiviral prophylaxis should not replace the annual influenza immunization, but rather it helps to control an outbreak. Influenza vaccination is a way to prevent the outbreak before it happens, whereas antivirals are a tool to use to combat an outbreak that is already occurring. If an individual is unimmunized, there are restrictions on them. There are no restrictions if they're taking antivirals every day until the outbreak is over. And if they are immunized during the outbreak, they have to continue to take antivirals for 2 weeks after immunization or until the outbreak is declared over. And for residents who are symptomatic at the onset of an outbreak, they need a treatment dose and assessment. If they become symptomatic after the onset of the outbreak and are taking prophylaxis, they need to switch to a treatment dose for 5 days and then back to that prophylactic dose, unless if they are lab-confirmed influenza treatment. If they are, then they are considered to be complete. Prophylaxis is recommended for all residents not on the line list, and most effective if started within 48 hours of symptom onset. Except, of course, there is a contraindication or they choose not to take it. And here you can see, although it is quite small, some flow sheets for antiviral use for residents. I will pause here just for a minute so you can take a look. And I know as soon as outbreaks start, one of the biggest questions we're asked is when can the outbreak be considered over? And it is dependent on the causative organism. Usually what we're looking for is no new cases in 2 incubation periods. However, recently we have been using what is called the 8-day rule, which is specific actually to influenza, as it's a period of communicability and an incubation period. During any outbreak, though, public health will consult with you as to when an outbreak can be declared over. And different factors need to be taken into consideration when declaring an outbreak over, such as how long it's been going on for, severity of symptoms, and ability to isolate. Here is a chart that is found in the guidelines for managing outbreaks in long-term care homes, which just outlines incubation periods and periods of communicability. So this brings us to the end of the recording, and thank you for listening to the 2021-2022 influenza recording year. If you have any questions, they can be directed to a public health nurse by calling 705-743-1000, extension 131, between Monday and Friday at the hours of 8:30 to 4:30 p.m. Please note, again, that even with the best planning and intentions, issues may arise with distribution and procurement. Thank you again for listening to this recording.